Good evening, ladies and gentlemen. Welcome to the Melbourne Brain Centre at the University of Melbourne and to this ICT for Life Sciences Forum presentation. My name's Luan Ismail. I'm the forum convener, and it's my great pleasure to welcome you here this evening. This evening's presenter, Dr. Paolo Bonato, received his Master of Science degree in Electrical Engineering from the Politecnico di Torino in Turin, Italy, and his PhD degree in Biomedical Engineering from the Università di Roma La Sapienza in Rome. His research interest is focused on rehabilitation technology, with special emphasis on mobile health technology and rehabilitation robotics. Dr. Bonato serves as Director of the Motion Analysis Laboratory at the Spaulding Rehabilitation Hospital in Boston. He's an assistant professor in the Department of Physical Medicine and Rehabilitation at the Harvard Medical School and a member of the affiliated faculty of the Harvard-MIT Division of Health Sciences and Technology, and an adjunct professor of biomedical engineering at the MGH Institute of Health Professions, and an associate faculty member at the Wyss Institute for Biologically Inspired Engineering at Harvard University. The twin realities of an ageing population and exploding health budgets challenge many advanced governments and advanced economies. Policymakers are looking to new technologies to enable people to be kept out of hospitals for as long as possible. Dr. Bonato's talk will examine developments in mobile health technologies and how they promise to address this growing health issue, the challenges researchers and health professionals face, and the impact on economies and societies from the emergence of mobile health systems. I'd like to acknowledge the financial support of the Australia Harvard Club Foundation in making Dr. Bonato's visit to Australia possible, and we're very grateful for the Foundation's generosity. So without further ado, could I invite Dr. Bonato to present his talk, The Doctor Will See You at Home, How Mobile Technology is Changing Healthcare. Dr. Bonato.
Thank you very much. Well, thank you, Luan, for the nice introduction. Thank you to the Foundation for its support. And thank you to Tarshan and Mary for being good companions in these few weeks of work together here in Australia. And Faris here, so thank you for your support as well. So what I'm going to do today, or this evening, is to give you a bit of an overview about the motivations that underline our work in this area of mobile health technology. And then I'll provide you with some examples and possibly with some discussion points toward the end of this talk. So I'll start actually mentioning what I trust you have heard being mentioned a number of times, the issues related to the aging population. We have seen a number of talks and papers about it, and I just decided to report here on the slide simply the cover of a report that the United Nations actually put out there a little while ago. And I really like the cover because they use what often people refer as the aging pyramid in the cover page. And they stress the changes, the dramatic changes that we actually are witnessing in the distribution of the population across different ages. And so what each of these towers actually represent is age on the vertical axis, and then the distribution of individuals from age 1 to 5 to 95 to 100. And this actually is the tower that represents the population in 1950s. This is the tower that actually represents the population in 2005. And these are the predictions for 2050. And it's very obvious that we have very good prospect. I'm very, very pleased about my expected life. So it's pretty good. But that unfortunately comes with lots of complications. And the complications are associated with the fact that with life expectancy, then you're going to have a larger population of older adults. And unfortunately, as we grow older, we tend to be affected by a number of medical conditions that need to be taken care of. And that, together with the increased costs of acute care, have really created what we call often, or refer to as a perfect storm. And so there has been quite a lot of interest, but from the clinical standpoint, as well as from hospital administrations and policymakers, toward exploring ways to actually do something that we're going to be very pleased with, which is to keep us healthy and out of the hospitals. And that's the technology that people envision to utilize to achieve this goal is mobile health technology. So it's the ability of actually monitor vital signs and patient status outside of the hospital setting. And this is becoming quite a revolution, certainly in the US, and as I travel across the world, thanks to numerous foundations and institutions that are very generous and allows us to actually get this exposure to what happens out there outside of the US. I see the same story shape in different ways according to the geographical and particular conditions of the areas that I visit, but I see really a similar story to what we actually witness in the US. Now, this technology has been around for a few years. There has been a moment of hype, and as you are familiar with the way technology is developed, there is always a bump at the beginning, and then a bit of a valley, and then the technology takes off. That applies to all the technologies with the exception of Apple products that actually just go straight up, right? But we're not as good as Apple, so what we develop follows the traditional curve of the first bump and then a moment of reflection, if you will. And so, in fact, many of us have been wondering whether our dream of what we call ubiquitous physiological monitoring, so these mobile health applications in the home and community setting, so monitoring individuals outside of the hospital is actually real, or it's simply something that, or wishful thinking, or something that we would love to do, but it's actually not going to happen. And so I want to start the talk actually trying to convince you that this is in fact going to happen, and it's not going to be a technology push. It's actually going to be a phenomenon that's going to be associated or driven by financial considerations, by the availability of technologies that have introduced a great deal of innovation in the field, and by clinical needs that we're going to need to address by utilizing such technologies. So as we look at financial driving forces, I want to make the example of the US, but as I mentioned earlier, and that has been certainly the case in Australia, as I've been engage in conversations with individuals here. I can see lots of similarities, not exactly the same system that we have in the US in terms of healthcare system, but a lot of similarities in terms of the way the healthcare system has been reorganized over the past decade. What we have seen in the US is certainly a major phenomenon of consolidation of hospitals into large networks. And I'll start actually presenting this in an anecdotal way. Because at least in my experience, that's the way things kind of stick to your mind. And so I'm just going to provide you an example, which is a personal example. I was at Boston University when I moved to Boston in '96. I was there for 6 years, and then I had the opportunity to move with Harvard Medical School in 2002. And I joined what is called the Spalding Rehabilitation Network of hospitals that's part of Partners Healthcare. And when I joined, we had about 250 to 300 inpatient beds, and we had 7 outpatient facilities. So a relatively small network. Over a period of 11 years, that's how long I've been with the network, we have increased our inpatient capability to close to 1,000 beds, and we have now 23 outpatient centers. So why is this happening? It's really happening for financial reasons. It's not happening because we provide a better service. We think we do provide a very good service, but the reason why we're going through these consolidations in the US is simply because by pulling hospitals together, the hospital administrations are actually gaining bargaining power with insurance companies. And so now let me switch to a non-personal way to convince you that that's the case. In fact, let me mention 2 of the papers that have been published in this area. And if you go on PubMed or any sort of major paper repository, you actually can find plenty of literature that even at the beginning of the last decade actually emphasizes how this was going to happen, how this phenomenon was actually going to drive the consolidation of networks of hospitals into large networks. This is a paper, for instance, that was published in 2001 that not only observed the phenomenon, but ran projections on the financial advantage of consolidating hospitals into large networks. And there's a paper that came out a few years after that, 2005, in which not only they emphasize that there was a financial advantage in building these networks of hospitals, but there was really no benefit to patients, that the quality of care that we were providing was really about the same that we would have provided if we had not pulled together these networks. So this is really a financial push. So now the reality is that the system that has led to this consolidation of hospitals in networks, it's driven by a business model that's a fee-for-service model. So essentially, the hospital system makes money when people are sick. They come through the door, and we get paid because we take care of patients, right? That system, as the reimbursements are going up, has created obviously a very strong financial impact, but also has been obvious that it's not sustainable. And so we can't just increase the costs of acute care and anticipate that those costs are going to be taken care of. And I'm not going to reference papers here, but I trust that even if you listen to politicians from time to time, which is not always advisable, but in that specific instance, they're going to mention for sure that the expenses related or the costs related to healthcare are now a really large portion of your GDP, right? And it's clear that at one point in time, that has to stop. And that's certainly the case in the US. In the US, we have been really at the forefront of the field. So we have the highest costs of healthcare in the world and not necessarily the best results. Fari does a lot of international work, so she could shame us because we spend so much money and then the results across the population are really not particularly good, right? And so it's very obvious that this is not going to last very long. And I often refer these as the process of squeezing the lemon, and there is really no drop left there. So we need to do something else. And so it's very obvious that all our network administrations are very sensitive to the topic, and in all the networks they actually started putting some thoughts of it. And what's happening, at least in the US, it's really the merging of large healthcare networks and insurance companies. So this is a phenomenon that motivated Kaiser Permanente. It's a large network on the West Coast. They're based in California. And the reason why they thought that this was going to be a good way to go about addressing the issue is because as they serve now as an insurer and as a provider, they can leverage the technologies that I mentioned earlier to keep people outside of the realm of acute care, so outside of the hospitals, but they can still make money out of it, whereas a traditional network of hospitals would not, right? And so it's not a good business model to keep people outside of your clientele, if you will, right? Because it's not going actually to bring in revenues. So I'm presenting this in a slightly cynical way because I want to emphasize that the drive here is purely financial. It's not actually clinical. So is this, though, going to be possible? Is the technology that's available out there going to help us implementing these capabilities of, or these opportunity, that's purely business opportunity, of merging healthcare networks and insurance companies and take advantage of it? And if I can mention just quickly another anecdotal fact, the network that I'm part of, Partners Healthcare, which is a very large network, the business of the network accounts for about $8 billion a year, so it's one of the largest healthcare providers on the East Coast. And the network, being sensitive to this topic, actually, as an experiment, acquired an insurance company 2 years ago. And the experiment is proceeding really well, so we expect that this is going to make good strides, so that there is a future for that. But do we have technology that is actually going to allow us to implement that vision, right? Because obviously, theoretically, it's great to think that we're going to prevent severe conditions that we're going to need to address in acute care by monitoring individuals in the field. But if we don't have the technology to in fact implement this vision, then there is an obvious gap in our business model. So it turns out that there are three elements that are emerging that are innovation driving forces, in my opinion, that are going to play, again, in my opinion, quite a strong role. One is the ability of actually monitor patients outside of the hospital setting. This is not only technology that we have developed, our group and others, over the past 20 years, but it's now even perceived as a possibility by the public at large. What you see on the screen right now is a screenshot from an advertisement campaign by a large insurance company in the US, UnitedHealthcare. And they have this very smart advertisement in which they show numbers kind of floating like a cloud around the person. And they try to convey with that advertisement that's been very, very effective, that their network essentially provides you with the ability of monitoring individuals as they go with their daily life. And so the reason why that's possible, it's because not only the technology is becoming available, but also because there is a perception that that's a possibility. So there is acceptance on the side of potential clients / patients. There is a need for introducing automation in this process, because as we gather a massive amount of information, we can't possibly think that physicians are going to do the work that I witnessed in the early 1990s when I got my first job in a research center, and I worked with a good group of cardiologists. They were actually going through Holter recordings, screen by screen, and obviously residents were actually doing that at night when they were on call. Not the best time to actually make sure that you pay attention to what you look at. But there was no automated processing of data that was collected using this system. And so that phenomenon obviously has been taken care of. There are a number of systems that now do whatever is necessary on those time series. It's not like 20 plus years ago when people actually had to look at EKG to figure out whether they had an ectopic bit or not, right? Those are things that are detected automatically. But now that we're looking into monitoring a massive amount of individuals and gathering a massive amount of information, it's clear that automation has to be in place. And again, there is not just the technology coming along, but there is also a perception that this technology is going to be useful and suitable. There is, on the screen now, a screen capture of the March issue of The Atlantic. I'm not sure that this is a magazine that's particularly popular in Australia, but it's relatively popular in the US. And they had just in March a very provocative title on their cover page, "The Robot Will See You Now," which in the article in the magazine actually elaborates on the variety of different robotic technologies that are going to be utilized in the next 10, 15 years in the healthcare system. And if you either work in a hospital or you had the unfortunate need of actually receiving care at a hospital, you might have seen some of this technology coming through. For instance, at Children's Hospital in Boston, all the meds management and some of the meals are actually distributed by robots that actually go around the units and take care of these sorts of things. So there is a lot of automation that has been coming to place, and I think that this is actually going to be quite a driving force for what concerns mobile health applications. And finally, there is a need for processing this information and the management of this massive amount of data has to be done in a way that's clinically meaningful. And what comes to mind, because not only because we have some representatives from IBM tonight here, but also because this project got so much visibility, is that a lot of what we have been doing by looking at charts and writing notes is going actually to be taken care of by systems that have the capability of processing information and providing back information to the clinical team in a way that is effective. And that's the Watson project and projects of this nature that have been pursued aggressively by a number of different groups. So the immediate needs that we're going to address clinically are three. The 30-day readmission rule, the need for managing long-term conditions, and not only the work that we're doing in secondary prevention, but the emphasis that we envision that primary prevention actually would be set in place. So, and I'm going to use the next 3 slides to elaborate on it, so forgive me if I'm actually sort of skipping things here and moving to the next 3 slides. So the 30-day readmission rule is something that's implemented in different ways in different parts of the world, but it is becoming actually commonplace, at least from what I can gather out there. In the US, what that means is that if a patient is readmitted after discharge within 30 days for a given condition and is readmitted to the hospital within 30 days, then there is no reimbursement in place. The hospital or the network of hospitals has to take care of that patient at no cost. Right? And obviously this has been put in place in order to maximize quality of care. What that means is that inevitably you're going to have cases in which you're going to need to see patients within 30 days and readmit them for that condition. And you want to minimize the severity of the conditions that you're going to deal with. And so because of that, there's been quite a lot of emphasis with investments directly made by hospitals into technology that allows us to monitor individuals after discharge. And so that is what used to be called telemedicine, that Joe Kvedar at Partners Healthcare sort of renamed Connected Health, which is all sorts of devices and systems to monitor vital signs and patient status in the home and community settings that connects, in fact, patients with their physicians through telemedicine type of tools. And again, this is becoming essential, not just because we want to take care of patients properly, but because there is a need for avoiding readmission from a financial point of view. Then there is an obvious need that is, again, financially motivated, that relates to the costs associated with the management of long-term conditions. And now all in a sudden, particularly because of these merging phenomenon between healthcare networks and insurance companies, now we see a lot of interest for applications that facilitate, or technologies that actually facilitates the management of long-term conditions. What I put on the slide here is a screenshot from a company that we have no relationship with, and I actually didn't have a chance to look at their product for glucose monitoring. And this is obviously related to the management of diabetes, which unfortunately is a very common conditions, and there are all sorts of complications associated with that, and therefore costs, and therefore the interest for addressing these type of conditions by preventing through what is called secondary prevention here, measures, exacerbations of the conditions of these individuals. So we see a lot of these type of technology, and if you live in a system that's not a private system, quote unquote, as what we have in the US, then it's purely an emphasis that is placed because of the relevance of this large population that I emphasized at the very beginning of the talk, where we have, with the growing percentage of individuals who are older adults, more and more individuals who actually are affected by long-term conditions and need to be properly managed. And addressing costs associated with that, it becomes extremely important from the point of view of maintaining the healthcare costs within boundaries. And then eventually, the third slide here emphasizes within this context, the need for implementing primary prevention plans. There are quite a few technologies that come actually from the wellness industry and that you probably are familiar with. Some of the Garmin applications, for instance, on cell phones, or some of the Nike products and Adidas products to actually track performance in the field. Some of the recent gadgets that have been advertised, the iWatch from Apple is coming to the market. We will see. We haven't had a chance actually to play with it. We will see how good of a platform that is. But these gadgets or gizmos, they're now available for wellness applications, not for actual medical applications. We envision that they're going to be utilized for applications of interest in the medical community. So on that basis, or with that sort of expectation, about 12 years ago, we actually started working on the concept that you see represented in this slide. What you see here is because of our emphasis and interest for rehabilitation applications, is a schematic representation of a person, for instance, with an incomplete spinal cord injury, who came to Spalding, our main campus, for the acute care, and then was discharged, went back home, and we want to follow that person over time, even if they're actually attended an outpatient facility that's remotely located. And so you see sensing technology embedded in clothing items, as well as on wireless strap and objects that actually allow us, or sensing technology that allows us to monitor these individuals as they undergo an intervention somewhere else, perhaps in a facility that doesn't have the medical expertise that's necessary to potentially address all issues that might affect the individual. And then through a variety of different means, mobile health type of technology, so cell phone technology, access points, and eventually through the internet, we related information to the sites where that information is needed. If the system that we're using is a personal emergency response system, then we're going to have a call center or emergency response center that is set in place. And if it's a clinical application like the one that I mentioned earlier, we might want to relay the information to clinical personnel or family and caregivers according to the needs of the application that we are pursuing. So this concept of monitoring individuals in the field, it's not a new concept. So it's important that we acknowledge that. In fact, if you think back at the end of the 1940s, beginning of the 1950s, that's when the Holter monitoring system was actually conceived. And this is a picture that I found on the internet of Norman Holter. And you can see this brilliant individual who had the intuition of pushing for monitoring cardiovascular relevant information, electrocardiographic data, for long periods of time, to detect things that we give for granted these days, right? The detection of an arrhythmia, for instance, right? It's something that we give for granted because we have access to this type of technology now. But back in the 1940s, early 1950s, obviously the technology was not as portable, as wearable as it is now. So the big backpack here is the electronics that they had to build in his lab. And it wasn't long lasting. I'm not sure whether it is on the bike because it's trying to generate enough power to actually get the electronics running, or actually because it's trying to run a test. It's obviously the latter, I'm kidding. But it's obvious that the miniaturization of the technology that we have witnessed over the last 20 years has been absolutely key in allowing us to, in fact, take the vision of Norman Holter and implement it. Right? And you see now a very compact system. You can get something that's pretty close to actually a standard EKG that is actually mounted on a watch. It's not obviously standard leads, but even a standard lead system would be relatively compact. It's like a pocket of matches, right? And you can actually store data for 48 hours with no problems, right? So what we're doing here is to take the vision of individuals like Norman Alter that was developed 40, 50 years ago, and then now finally implemented because the technology is currently available to us. The two technologies that we're leveraging upon are textile solutions or e-textile systems and wireless technology. So let me just show you some examples of wireless technology. These are a variety of systems. I borrowed this slide from Nat Sims, who is one of the leading individuals in this area, and a colleague and friend who works at MGH, so just next door, part of Partners Healthcare, so same system. So we have been interacting quite a bit. And he is a anesthesiologist by training, so it obviously has an emphasis on vital signs. And obviously you see here in the slide a number of different systems, very smartly designed, that gather electrocardiographic data or data that's relevant to assess cardiovascular health. This is, for instance, a system that has a lot of computational capability in that small box that detects all sorts of interesting or medically relevant occurrences from EKG, and then relays through wireless technology an alarm signal wherever that is necessary. These are e-textile solutions. This is the work or the result of the work of Sandarazan Yairman at Georgia Tech. He came out with the idea of embedding fiber optics into the fabric of undergarments quite a little while ago, about 15 years ago. And there was a project sponsored by DARPA, very visionary. What he wanted to do, in his word, more or less, is to actually have the ability of plugging sensors directly into the fabric and then use the fabric essentially as a computer bus and relay that information to a data log unit or a unit that has the capability of processing that information. And the other systems that you see in the slide here are systems of design and manufactured by a number of other groups. I know that in the audience we have a person who works actually with the Rossis group quite a bit. This is one of the results of the technology developed in the Rossis group that has been leading a number of projects sponsored by the European Commission. This was, I believe, part of the My Heart program. They actually embedded the capability of sensing technology that provides you with the ability of monitoring vital signs and even movements, actually in undergarments of this nature. So very nicely integrated into textile solutions. But eventually all this information goes into a mobile platform, and I borrowed this slide from Julian Penders, who works at IMEC in the Netherlands. They have a site, their headquarters are in Belgium, but they have a site in Eindhoven that focuses a large portion of their activities on what is called the Human++ program, which is very much geared toward developing all sorts of technologies to monitor individuals in the field. And I really like this picture because it does convey the fact that we deliver or relay that information to a clinical site through all sorts of mobile applications. And so obviously cell phones are an obvious means to achieve that goal. So let me show you a few examples of clinical applications of these technologies. So what are we attempting to do by leveraging upon these capabilities? So I'll present 5 examples. So the first one is the management of patients with late-stage Parkinson's disease. It's unfortunately a condition that is relatively common in older adults. About 3% of the individuals above the age of 65 years are affected by Parkinson's. It's typically managed effectively. We have neurologists here, so it's typically managed effectively with medications in the early stages. There are aspects that might be not strongly responsive, like akinesia and freezing of gait. But tremor responds well to Sinemet, which is levodopa-carbidopa. So to drugs that actually supplement or boost dopaminergic pathways, which are the deficiency, or which is the deficiency that actually causes these symptoms that are associated with Parkinson's. But unfortunately, over time, these patients, they become more complex, and they suffer what are, or develop what are referred to as motor complications, which are what patients would report as a roller coaster. And so they would take their medication, that's what is represented here on the bottom of the slide. They would take their medications. The medication would attenuate tremor, so they would be in what people call the on stage. But during the on stage, they would see the severity of other symptoms and motor complications to vary very dramatically over time. For instance, dyskinesias are very hyperkinetic movements. There are involuntary movements that are very impairing the individual, and they're socially not pleasant or easy to accept. And so patients are often embarrassed about it. And unfortunately, what happens is that subjects would experience the severity of these movements, these kinetic movements, to go up and down during the period in between two medication intakes. On top of it, what happens is that one of the characteristics of this condition is that subjects would not have an objective perception of their motor status. So it's very difficult for them to go to the neurologist, and during the 15-20-minute visit that it's going to be performed, actually report about the effectiveness of their meds. And so what we have decided to do with David Standard at MGH and John Groudon, as well as Dan Tarsi at Perry Stella Medical Deaconess Centers. These are major contributors to the field. For instance, John Groudon was among the investigators on the first levodopa carbidopa trial in the 1970s, so it's been a pleasure working with people like him. But what we have decided to do is to use sensing technology to actually monitor the severity of symptoms and motor complications over time. To do it periodically for periods of a week or so before outpatient visits, and then to provide these profiles of changes in the severity of symptoms and motor complications over time before the outpatient visit, so that the need for titrating their medications can actually be assessed. And so, for instance, what you see here are visits performed in February, June, and October. These are actual data from patients. You see this red square that represents the time of medication intake. And then you have different trajectories that represents on an ordinal scale the severity of tremor, bradykinesia, which is slowness of movement, and dyskinesia, which is these hyperkinetic movements. And this is interesting because, for instance, the adjustment of medications for tremor and dyskinesia are in the opposite direction. So it's very relevant to know if you are increasing the dosage excessively, leading to excessive dyskinesia versus you don't attenuate tremor effectively. Another application that we've been focusing on, this has been with Dr. Moy at Harvard Medical School. She started her activities at Brigham Women's Hospital and moved to the Veterans Administration System recently. And she is in charge of a large program that's focused on the management of patients with chronic obstructive pulmonary disease. This is unfortunately a condition which is very common, particularly in heavy smokers. And so there is major campaign, obviously, in all countries to try to limit abuse of smoking. And what happens in these individuals is that after they go through diagnosis, unfortunately, they have no cure available to them. And so what you do is that you essentially manage them, hoping that they're going to be lucky enough to actually be subject to lung transplantation, which is the only available solution at this point in time. Everything else is pure management and sort of kicking the can down the road. So, kind of stretching things as much as you can, if you will. And so what we have decided to do is the following. The reason why, unfortunately, lots of patients, they don't reach the time of lung transplantation, even if a donor might be available at some point in time. It's because they go through what are called exacerbation episodes. And these lead to hospitalization, so they're associated with infections, fever, etc., etc. And the reason why it's often the case that they're so severe is because they are underreported. So we decided with Dr. Moy to take a number of different technologies to look at activities, to look at systemic responses. This is a system, for instance, that clip on your earlobe and actually grabs data that relate to the amount of oxygen in your blood, right? So it's oxygen saturation. And what we're looking at are systemic responses associated with a variety of different motor activities. And what we're attempting to detect are trends into systemic responses that mark systemic responses that are associated with a given motor task. And we categorize or stratify tasks according to how demanding they are from a systemic point of view. So if a subject goes up a flight of stairs, for instance, and the response changes very dramatically over time, that's a time where we actually want to check on that patient more closely. So that's obviously an hypothesis. We haven't demonstrated that we're extremely effective in doing so. But unfortunately, what's available out there, which are things such as spirometry, which is essentially when you blow into a tube and you actually measure your flow, they're very ineffective. They're very unreliable. And so we are desperate for measures to actually monitor these patients effectively. So the third project that I want to talk about very quickly is the project that I'm in fact running with Tarshan and Mary and Faris group here, thanks to the support from Luan and the NICA group, which is monitoring motor recovery in patients after a stroke. This is relevant because we're fortunate enough, at least in my opinion, to have so many potential alternatives and possibilities of interventions. Our group is particularly interested in combining pharmacotherapy with very aggressive rehabilitation interventions. And it's just a matter of fact that not all the patients are equally responsive to all the interventions. And so monitoring or tracking actually what happens in terms of motor recovery in response to these interventions is very, very relevant. Two more projects. The first one is on cerebral palsy. We embedded sensors, for instance, in sneakers like the one that you see here, and we did it across a variety of different ways to actually gather data from this patient population. And we've been actually using this technology to monitor kids after interventions such as a botulinum toxin injection, where we actually look at the effectiveness of the intervention and the wearing off. So it's still in the context of assessing the effectiveness of the interventions and monitoring them to figure out if it's necessary for us to actually call them to go through an outpatient visit and take care of potential problems that they develop over time. And the same for this other application in which we embed a sensing technology into a knee sleeve in patients with knee osteoarthritis. We were interested, pharma was actually interested in working with us to figure out if the medication that we're testing was actually effective in maintaining a good level of activity and in these individuals avoiding problems associated with pain. And they wonder whether, in fact, the effectiveness of the drug was actually had an impact on range of motion during the day and the type of activities that individuals were actually engaging to. So we essentially embedded sensors into these knee sleeve, and we got it to talk to a cell phone and relay data to a remote site accordingly. So in all these projects, what we're really trying to do is to implement what was the vision of Norman Alter, of actually monitoring individuals, gathering vital signs and all sorts of medically relevant information outside of the hospital setting. And this is a picture taken by one of my postdocs who is a very good photographer. And you see it was obviously on vacation in Italy, and there are lots of happy people there who live a long life. And so I managed to get the shot where you have all these older adults that are engaged into all sorts of activities. And it's very likely that people in the picture actually do have needs, medical needs that actually require medical monitoring. That's the reason why you see all these numbers on the screen. So what are the challenges in the field? And I'll close with 3 more slides. The challenges are the development, the following 5 in our opinion. So we want to develop systems that are really easy to wear so that people actually forget about wearing. So they're not going to be purely monitoring devices, but are devices that actually are part of your clothing items, and they gather information in a seamless way. From a technical point of view, so for those of you who have an engineering background, it's certainly the case that power requirements are a major need, and there are all sorts of scavenging technologies that are coming out there that are of great interest to us. There is quite a strong need for making sure that we extract clinically relevant information from these data. And so about 10 years ago, we got funding from the National Institutes of Health for our first project in this area. And we put the emphasis on using data mining techniques to take these very large data sets and figure out what's actually relevant from a clinical point of view. If we want to deploy these technologies in a clinical setting, it's absolutely necessary that we provide the information in the standard clinical flow. For us, would be plugging information into electronic health records. And if we want people to be compliant with the use of monitoring technology, particularly in conditions that are not associated with severe impairments, where patients might have extra motivation to do it, we need to embed the sensing technology into either objects that people are going to carry with themselves for other reasons, or objects that are actually embedded in the environment. And so in that area, which I think it's going to move quite quickly over the next few years, what I envision is that first we're going to see the integration of sensing technology into systems that leverage technology that's going to be available in the home setting. First, for personal emergency response system. The system that we provide as Partners Healthcare to older adults, that is also very popular across a number of different hospital networks, and it's available as a service to the public at large, is provided by Philips, the Philips Lifeline. So this is essentially a pendant with now some sensing technology that can actually identify when a person falls. And it's obviously used for fall detection and all sorts of alarm situations that might occur in the home setting. Now, unfortunately, what happens is that in order for the system to be effective, it's absolutely essential that the system doesn't miss an event. And so what that means is very, very high sensitivity. But as people in the audience who have engineering background know, when you have very high sensitivity, inevitably you're going to have false alarms. So that's the reason why my grandmother doesn't use the system, and we bought the system for her. It sits on the nightstand. And the reason why it does is because it goes off too many times. And so she gets annoyed, right? But you cannot achieve the goal technically otherwise, because the cost of it would be to take a chance of a false negative, so that she might actually fall and the system would not actually be able to capture that. So that's where the integration with other technologies comes in. And the technology that we have played with is what you see in this video clip that was pulled together by a brilliant student that I got to come from Switzerland to Boston for about a year. And so what we decided to use is to leverage home robots. So what the system does is that the robot is actually part of a network of sensors that are embedded in the environment. What you see in the video clip is obviously a simulation. A sensor in the environment would relay an alarm signal. The robot would gather that information through the network that's of sensing technology that we have in the apartment setting. And then it would go and check on the person, so that as opposed to have to push the button or have to have a communication with the call center, the robot, like a pet, would actually crawl and go to the person and would interact with the person. Right? We think that this integration of technologies is actually going to make quite a difference in the near future. So let me wrap things up here so that we stay at least relatively on time. So I wanted to convey 3 things during this talk. I wanted to share with you our thoughts of what we're witnessing in terms of major transformations of the healthcare systems. And I wanted to try to convey that at least the way we see it is a push toward an emphasis on long-term care, primary and secondary prevention versus acute care. Not that acute care is not going to be essential, it will be certainly in the future, so we're not trying to diminish the relevance of it, but we are trying to make the point that not only from a clinical standpoint, but also purely from a business point of view, the healthcare system is going to have a major emphasis on these conditions that go way beyond acute care. We see the evolution of this process going through two steps. The first one that will be focused on monitoring individuals after we take care of them in the acute facilities. And a second phase in which the emphasis will be first on secondary prevention, so the management of long-term conditions, so there are no further complications that are going to be set in place, and eventually primary prevention. Because once the system is going to look at the balance sheet and consider the costs across the board, then actually keeping people healthy, it's going to be very attractive, not just from a clinical point of view, but from a financial point of view. So we think that there are going to be a lot of new tools that are going to allow us to transform the way the healthcare system actually takes care of patients. So before my last slide, I just wanted to thank again the Harvard Club of Australia. It's been quite a pleasure. I've been here in Melbourne. I have the possibility of interacting with a number of people in Australia. So I recommend, as was done earlier, that if you either have some good friends at Harvard or you want to visit Harvard, you just go on their website and look at the application mechanism. It's been really a pleasure working with Tarshan and Mary, the team at the Rehab facility that Fari oversees, the hospitality of Luan, and the rest of the NICTA team has been phenomenal. So thank you so much for that. You are welcome to go to our website. There is plenty of information on projects that we're running, or simply drop me an email message down here, and I'll be more than happy to send you additional information about these projects. Thank you very much.